introduction for Dr. Alan Schwartz, who certainly needs no introduction. Dr. Schwartz is a world-renowned sleep specialist who co-directed the Johns Hopkins Sleep Center and Sleep Research Center, has authored more than 150 publications, and has been intimately involved in developing novel technologies, particularly wearable type devices for sleep diagnostics. And we're very much looking forward to hearing from his world-class expertise today on the WatchPAT technology. Thanks, Dr. Schwartz, for your time.
You bet, and thanks so much for having me. It's really good to meet people virtually, and encourage you really to stop me. It's a small enough group, I think, so feel free to just stop me if you have any questions. This is new technology, it sounds like, particularly for the Canadians among us, so not a problem. I'm going to share my screen. Just want to confirm that we're seeing the screen itself. How's that? Are you guys seeing my?
I can see your background there, your desktop.
Yeah, perfect. Okay, good. All right. Well, yeah, so this is a WatchPAT overview, but it really is an approach to home sleep testing, and it's a somewhat different approach. I got frankly stuck into this business over 20 years ago when the PAT signal, the peripheral arterial tonometry signal, actually came about. It wasn't yet incorporated into the WatchPAT device, but was really a novel marker for sympathetic activity in the peripheral vasculature. And as you'll see, many years later, probably several years ago, I got involved once again as some of the Itamar people approached me and asked, why don't you use the WatchPAT? And I said, I really don't understand how it works. And it was really from that initial conversation that we struck up a project that is shown here called the Compass Project, a comparison of WatchPAT with sleep studies. And as an outgrowth, I began to get reacquainted and fascinated by the physiology of the WatchPAT and its ability to be deployed in the clinical setting for home testing. And so without anything holding us back, a disclosure slide here, been involved with a lot of different respiratory technologies, but in particular, phrenic nerve stimulation through the years, as well as hypoglossal stimulation and some other diagnostic and therapeutics. I'm sure most of you are familiar with sort of traditional flow-based home sleep apnea testing. And I'll start here just simply to say that most of these tests, and I'm not sure exactly which platform you're using at this point, but most of these tests are really essentially based on the nasal pressure cannula at the nose, or an oronasal cannula at the nose and mouth. And these are essentially cardiorespiratory studies that are stripped down from full polysomnography and provide us disclosure of traditional respiratory signals, such as the oximetry, the flow, and the respiratory effort. It's really from these studies that we can detect the decreases in flow, whether or not they're accompanied by an increase or a decrease in effort, as might be the case with obstructive or central episodes, accompanying desaturations. And then for the whole night, these devices, you can count up the numbers of apneas and hypopneas. But interestingly, from this type of device, which characterizes most of the devices in the home sleep apnea testing space, from this type of device, arousals and sleep staging are completely left off the table. And that's what makes them really well suited for home testing. But it's really on that basis that we're really obligated to generate what is called, rather than an AHI or an RDI, a respiratory event index, which is given by the numbers of apneas or hypopneas divided by the total recording time rather than total sleep time. And since individuals don't sleep for the entire night, the recording time tends to be an overestimate of total sleep time, and it makes these devices somewhat less sensitive in picking up and classifying sleep apnea based on severity indices, namely AHI in ranges of 5 to 15, 15 to 30, et cetera. WatchPAT sort of turns this story a bit on its head. And so what we'd like to do here over the next few minutes is really talk about the underlying PAT technology, discuss briefly an approach to looking at the reports and the recordings so as to give you an overview, and then really talk specifically about how we can look at the WatchPAT reports and recordings to diagnose sleep apnea. And I'd like to highlight really three major questions that WatchPAT really puts us in a very good position to diagnose the different forms of sleep apnea that we see, namely REM versus positional sleep apnea by virtue of the fact that WatchPAT generates a hypnogram and has a body position sensor. We'll talk briefly about estimating the AHI based on the underlying native signals of the WatchPAT, which are distinctly not flow-based. And then we'll speak briefly about using WatchPAT to distinguish obstructive from central events. And then finally, I'd like to just simply highlight the fact that if we decide to delve a little further into it, we'll be able to outline a roadmap for learning how to visually overread and manually edit the WatchPAT reports and recordings based on formal scoring guidelines that we've developed during the COMPASS project. The technology really consists of three components. The button here that you see in the lower part of this panel really sticks to the upper chest or manubrium. And it's invested with a body position sensor, a snoring mic that's relatively well calibrated, and a chest motion or respiratory effort sensor. The wristwatch device is the guts of the device, but embedded in it is an actigraph. And the actigraphy is really used to help us distinguish sleep from wake. But the backbone of the device is really the finger probe. It's a hard plastic encasement of the finger that includes in it two sensors, the PAT signal or peripheral arterial tonometry signal, and an oximeter. Now the PAT signal is an index of vascular tone in that it provides a pulsatile, beat by beat pulsatile signal. The amplitude of this signal is really an index or reflection of the overall caliber of the arterioles in the finger. But by the same token, because we get a high fidelity beat by beat signal, we can also derive, or WatchPAT derives, the heart rate or the pulse. And so this probe throws off, the PAT signal throws off an amplitude and a heart rate signal. And the oximeter is also embedded. What is the underlying core PAT technology? Well, the jacket that fits around the finger is really designed to provide a uniform counter pressure around the blood vessels in the finger. And so when we see a pulse pressure or a pulsatile waveform coming through with each systole, that counter pressure really allows us to pull out the signal that is due to the beat by beat pulsatile nature in the arterioles itself. The photoplethysmography signal, which we're accustomed to seeing with oximetry, is used to generate the underlying pulse volume. But that pulse volume is conditioned, as I said, mechanically by this finger jacket, so as to increase the signal to noise ratio. It specifically damps out venous pooling in the finger and allows us to extract more purely the pulsatile nature in the arteries themselves. And as a result, because finger arterioles are innervated very, very richly by adrenergic, by sympathetic fibers, the fact that we're able to get the pulse volume of the arterioles increases the sensitivity in our ability to detect sympathetic activation or surges of adrenaline that might accompany arousals or changes in sleep-wake state. And in the end of the day, it's this combination that is relatively unique that gives us our index of peripheral arterial tone. Well, we see that that pulsatile nature, when the finger is in this probe, the probe itself exerts a uniform counterpressure. And because of that, we've actually increased or changed the transmural pressure in the artery itself. We've put that artery in a more advantageous portion of its pressure volume characteristic. And as a result, for any change in pressure, we see a much greater change in finger volume when we're measuring pulse plethysmography with the WatchPAT probe around the finger. And so we've essentially taken a damped signal and enlarged it considerably by virtue of the fact that we have that uniform counterpressure applied. Well, as a result, as I mentioned, we're preventing venous pooling. We also actually are able to decrease the motion artifact as the fingers move with movements. Respiratory artifact is also attenuated. As mentioned, we increase the pulse volume changes. And this is one uniform probe that fits all adult fingers. Having sort of nailed down a little bit of the basic sort of underlying PAT technology, what I'd like to do is I'd like to show you and describe the approach that we take to reviewing the WatchPAT reports and on occasion dipping into the recordings themselves. We'll do that here by looking at really how does WatchPAT generate an AHI? Well, in contrast to the flow-based technologies that we discussed a moment ago, we're not measuring flow per se, but instead we're teeing off these surges of adrenaline, adrenergic surges that accompany microarousals from sleep, as might occur at the termination of apneas and hypopneic episodes. When we pick up in the WatchPAT a microarousal, we see that as represented by an attenuation in the PAT amplitude. And so what we see here is the PAT signal compressed here for this 3-minute screen. The PAT signal, its pulsatile signal, is shown here in raw form in this panel. But the moving average of that signal, or the envelope of that signal, is shown here as the PAT amplitude. And in this example of several minutes, you can see that there are discrete attenuations in PAT amplitude that occur, indicating that there's been an intense vasoconstriction in the arterioles in the finger. When that vasoconstriction, seen here in PAT amplitude, is accompanied by a rise in pulse rate, we really have a high degree of confidence that there's been a blast of sympathetic activation or a microarousal from sleep. And we'll call that drop in PAT amplitude and the rise in pulse, when it occurs simultaneously, we'll call that the reciprocal pattern. And the reciprocal pattern is WatchPAT's underlying mechanism for detecting the microarousals that terminate sleep-disordered breathing episodes. But as you all know, microarousals are not terribly specific for sleep apneic episodes. And so to call this a sleep-disordered breathing event, whether it be central or obstructive in nature, we're looking for some other index or indication that there has been a disturbance in ventilation or oxygen. And that disturbance in this example comes by way of desaturations that accompany each and every one of the reciprocal patterns or microarousals. But as mentioned, WatchPAT also provides us a surrogate for flow, namely the snoring signal, and a respiratory effort signal. And so we can use these signals as well, as we'll see in a moment, paired with the microarousals to classify our sleep disorder breathing events. WatchPAT goes one step further because the underlying PAT signal and the actigraph are used in concert to actually generate a hypnogram. And the hypnogram gives us total sleep time, non-REM, and REM times. And it's because of that that we can actually generate what is truly an apnea-hypopnea index. And that index is based namely on the numbers of apneas and hypopneas divided by total sleep time rather than total recording time. And it's for that reason that in contrast to the flow-based home testing technologies that divide their disorder breathing events by total recording time, WatchPAT provides us a highly accurate estimate of AHI because those breathing episodes are divided by total sleep time. We'll take it one step further in a few moments, and we'll show you how generating an AHI during non-REM and REM sleep is of pronounced diagnostic significance. But before we get there, let's talk about just give you an overview of the approach that we take to reading these studies, since they are sort of different from the usual flow-based technologies that we use both in and out of laboratory. WatchPAT really turns the process of scoring sleep studies on its head. It automatically scores the sleep studies and generates an automated computer-generated report that is based on throwing score tags in the underlying recording. And you have the opportunity to see those score tags if you choose to. But the report is generated here automatically by the computer. And so our job becomes one of confirming its indices of sleep architecture and sleep disorder breathing. And then when we raise questions as we visually sort of review and analyze the graphic display and the tabular data on the report, we can target areas for greater scrutiny. And it's really in a selective and a very judicious fashion that we occasionally then open up the recording when we have questions about the automated or computer-generated report. And it's after we do that that we either verify or edit aspects of the recording that we're able to then generate our final report that we stand by when we issue a report from the center off to referring physicians. Let me just give you a feel for how WatchPAT looks at sleep disorder breathing events and sleep staging. We know that with patients who have obstructive sleep apnea, there are varying degrees of airway patency during sleep, from a fully patent pharynx to one that's partially obstructed or hypopneic to one that's completely occluded or apneic. How does WatchPAT see those events in its recordings? Well, you see here in this recording 3 such events. And I'm only showing you here the snoring, SpO2, the raw PAT signal, the beat-to-beat pulse signal, the PAT amplitude, and the pulse rate. And you can see here in the PAT amplitude and the pulse rate that we have actually 3 so-called reciprocal patterns, where the PAT signal attenuates roughly at about the same time that the pulse rate increases, indicating that we've had a microarousal. Now, WatchPAT has dumped in score tags for sleep disorder breathing events, both for the events themselves plus the oximetry. But we can tell in this case from the snoring signal that this first event is associated with crescendo increases in snoring. And those increases in snoring indicate that the airway is only partially but not completely obstructed. In other words, this is an obstructive hypopnea. not a complete apnea. The other two events are characterized by respiratory silence here, or apnea, that is terminated by one or a series of resuscitative snorts. The resuscitative snores coincide exactly with the period when the patient had the microarousal from sleep. So this is someone with complete apnea in these two events that terminates with microarousal and resuscitative snorts, or opening of the airway. Well, we'll see in a moment how we can put that information to good use as we classify patients as having predominantly obstructive versus central sleep apnea. But before we do so, I wanted to also highlight how WatchPAT actually looks at sleep staging, because the Hypnogram provides us really vital diagnostic information for classifying our patients with sleep apnea, as we'll come to see. We can view WatchPAT sleep staging in 60 to 120-minute windows. And this is, once again, a real WatchPAT recording, a 60-minute window, where we see here now a full WatchPAT study or set of signals: actigraphy, body posture, snoring, SpO2, the raw PAT signal that's highly compressed here, the derived PAT, and the pulse rate. Now, in this case, we can see that as we just look at the derived PAT, or the PAT envelope, we see that the amplitude of this signal, the level of this signal, is relatively high in the first 20 minutes. It dips down in the second 20 minutes, and then goes back up in the last third of this 1 hour window. But not only do we see that the change in amplitude occurs between these three segments, but we can also see that the variability that's inherent in this signal changes as well. In this first third, we see a pattern of very regular variability. So a high amplitude signal that's variable, but relatively regular or oscillating. In the middle third, when the amplitude goes down, we see really a chaotic pattern of increases and decreases in heart rate in a really chaotic, unorderly pattern. And that pattern of irregular fluctuations in the PAT signal, that pattern of variability, is also reflected in our pulse rate, and it's reflected in our oximetry. In other words, autonomic control goes haywire here, while at the same time, we have evidence that there is an intense vasoconstriction in the arterioles of the finger, because that vasoconstriction is marked by a drop in the pulse waveform amplitude. But sure enough, the patient probably aroused here with a movement and goes back into a period here of higher amplitude and lesser variability, both in the PAT signal as well as in the heart rate. Well, it's really on the basis of these changes in both the amplitude of the PAT signal, as well as the patterns of variability that you can discern, that WatchPAT can automatically stage this 60-minute window as periods of non-REM sleep flanking what is largely a period of REM sleep in between. REM sleep being characterized by an intense vasoconstriction leading to the drop in PAT amplitude and the chaotic irregularities or variability in all autonomic signals that is really characteristic of REM sleep, particularly when there are rapid eye movements. But we can also see a short period of awakening that's characterized again by a vasoconstriction, a drop in the PAT amplitude, a bump up suddenly in the pulse rate, and a movement here in the actigraph. And so it becomes very easy in 60-minute windows for you, as you get comfortable with this montage to really just do a quick visual cross-check of WatchPAT's hypnogram. Now that visual cross-check, I'll illustrate here in this next slide, where I'll focus you here on the oxygen saturation and the pulse rate. And you can easily see that there are periods here where the oxygen saturation is a little bit more variable, where I'm pointing the cursor, somewhere in here. And the pulse rate itself matches in that it too is a bit more variable. And indeed, those periods here are REM sleep periods. And you can confirm that visually, not by going into the recording, but you can see that what WatchPAT has automatically scored as REM periods is plausible based on what you can see in both the amplitude dipping in the oxygenation as well as the increased variability of these REM periods compared to the flanking non-REM periods on either side. Another example here, which is characterized by, and you can see once again, characterized more by sudden increases in the pulse rate. And you can see that here, here, maybe here, here, and here. And indeed, those increases in pulse rate are largely attributed to REM sleep, an increased sympathetic activity. Adrenergic tone increases during REM sleep. And indeed, very quickly, you get the visual cross-check where you can look at your oximetry and your pulse rate signals and generate your own mental impression or plausibility check on WatchPAT's determination of REM. Well, if these are REM periods, then the flanking periods are most likely non-REM sleep. And that really only leaves wakefulness, where oftentimes the oxygen saturation is a bit higher and the pulse rate itself is a bit higher. You can often see those periods of wakefulness at the beginning of the night, before sleep onset, and at the end of the night when the study terminates. And so very quickly, you're able to do a visual cross-check, coarse as it may be, for WatchPAT's automated scoring or staging in generating the hypnogram. Well, it turns out that the hypnogram itself is really helpful because it helps us really distinguish at a glance. It helps us distinguish. The hypnogram helps us distinguish specific patterns of sleep disorder breathing, namely REM-related sleep apnea or positional sleep apnea. And we can see once again at a glance what those patterns look like, only from the report itself. Now, this study was taken from the COMPASS project, in which we monitored with a WatchPAT on patients who came into the laboratory for a full polysomnogram. And you can see here that WatchPAT's hypnogram matched the more granular hypnogram that's generated by epoch scoring on the polysomnogram, with the REM periods shown in red here, non-REM periods intervening. But what's most obvious here is the fact that there are clusters here of desaturations, here, and maybe a little bit here. Those clusters of desaturations undoubtedly represent periods of intense apneic activity. And compared to the non-REM flanking regions on either side, you would bet that this patient's REM apnea is considerably more severe than non-REM apnea, simply by virtue of the fact that indeed desaturations match the REM periods here, as you see here. It's not only that, but you see that there's increased variability in the pulse rate and somewhat of an increase in pulse rate during some of these REM periods. Once again, giving you visual confirmation that WatchPAT's hypnogram, its determination of REM sleep, is probably not too bad. Well, indeed, this is a patient with predominantly REM-related sleep apnea. The pathogenesis is usually attributed to a loss of neuromuscular activity in pharyngeal muscles, including the genioglossus, the major protrusion muscle of the tongue. And indeed, during REM sleep, we oftentimes see worsening upper airway obstruction during sleep, leading to the emergence of isolated REM sleep apnea with relatively little non-REM sleep apnea. Well, this patient ended up having very mild sleep apnea and non-REM sleep, but a REM-related AHI of about 45 episodes per hour, not surprisingly so. But I would focus you here on the fact that this is diagnostic, primarily because we see the REM periods well demarcated here in the automated hypnogram. Well, we'll compare that to what we see, in fact, when you see similar clusters of REM, of desaturations, as you do in a patient with positional sleep apnea. And once again here, we see roughly 3 or 4 clusters of intense, repeated desaturations that occur. But in this case, the apneic activity that these represent are not related to REM sleep, but rather more closely related to position. Body position is represented here on the top pane, where you see the patient in supine position at the lower level here, and side positions above. And indeed, when this patient has moved into the supine position, as you see here in the center cluster, you see that indeed supine position maps to intense apneic activity. Now, this is only a handful of patients that have predominantly positional sleep apnea, but we get additional confirmation of sleep disorder breathing. We get it from the fact that the patient is snoring intensely when he rolls onto his back. And that intense snoring in association with the DSATs suggests that indeed, if we were to look at the recording in detail, we're likely to see a lot of obstructive hypopneas and not apneas. But once again, what we've got here really is what is highlighted here in this report, and that is that not only do we have PAP-related therapeutic modalities available to us, but in this case, absolute confirmation that positional therapy is also possible for treating this patient. And the advantage of positional therapy is really just summarized here in the right-hand panel with a meta-analysis showing that the AHI with side position goes down significantly when positional apnea is present. I'm going to stop here if there are any questions. We've discussed the approach to looking at WatchPAT reports, and we've begun the process of really highlighting how we can use those reports to confirm the hypnogram and to make sort of visual confirmation or plausibility checks on REM-related versus positional sleep apnea. I'll continue then and look at the reports, but delve briefly into the recordings to highlight how we can use WatchPAT as a device for estimating AHI visually and confirming what WatchPAT actually generates as its automated AHI, and how we can also use the reports and the recordings to distinguish obstructive from central episodes. Well, for doing this, let's look at a case. This is a 53-year-old man, an American, with a BMI of 81.7. No mysteries here. He's severely obese. And so we're more than likely going to find a lot of sleep apnea. And the questions that we'll ask here are twofold. First, what is the severity of sleep apnea? Namely, what's his AHI, and can we visually cross-check? And second, are the events obstructed or central in nature? since patients in this weight range often have Pickwickian syndrome. With volume overload, they may be prone to developing central or Cheyne-Stokes breathing patterns during sleep rather than obstructive episodes. Well, let's take a quick glance at his WatchPAT report. Now, my view here starts with the report, but it starts specifically not with the tabular data, but it starts with the graphic display. Because the graphic display is where I really generate all of my impressions and my questions. And then I'm on a hunt just to confirm my impressions in the tabular data, and then as a next step in the recording itself. Now, when I look at this graphic display, my eyes tend to focus initially on the oxygen saturation and the pulse rate in red here. And there's no surprise that this patient has frequent deep desaturations. And most of you would guess just from the O2 saturation curve here for the whole night view that this is someone who has severe sleep apnea, certainly less than 30 an hour, but more likely less than 60 or maybe even 90 episodes an hour. And as this patient goes off to sleep, we see that the heart rate variability increases dramatically. That increase in heart rate variability is really just a reflection of the fact that the patient is awakening every half minute to minute from one of these apneic episodes. But as we look a little bit more in detail at this graphic display, we can see that indeed there are periods of deep desaturation shown here, here, and here. And indeed, 3 of 4 REM episodes are associated with these periods of deep desaturations. So it looks like this patient's sleep apnea perhaps gets a little bit worse in REM sleep, certainly in the severity of desaturations. But sticking to first things first, you can guesstimate an apnea-hypopnea index in both non-REM and REM sleep that's in the severe range. And we see that here with an AHI generated by the automated report in REM sleep 84 episodes an hour and an AHI in non-REM sleep of 96 an hour for an all-night AHI of 94. And indeed, these AHI values are buttressed by oxygen desaturation indices, which nearly match 1 for 1. So there's no mystery here that this patient has severe sleep apnea. You can go on if you'd like to and see whether the rate of apneas is roughly correct just by looking at a 10-minute screen on the recording itself. Now, this is the real interface on the WatchPAT, where we see here for the all-night view, the hypnogram. Periods of REM sleep are shown in red or rose color, the 4 REM periods that we saw. The events are marked off in tick marks here. And the period of interest, in this case, the 10-minute period, is shown here in lime green. And it's that lime green section, 10 minutes, that we're expanding and zooming in on the actigraph, body position, snore, O2 sat, PAT signal, PAT amplitude, and pulse rate. And indeed, in this 10-minute window, we count up roughly 15 or 16 reciprocal patterns, shown here by the decrease or attenuation in PAT amplitude and a concomitant rise in pulse rate, indicating that we've got a microarousal from sleep. And we confirm that these microarousals, which are occurring fast and furiously and periodically, are associated with desaturations and with sudden resuscitative snorts during the arousal itself. So if you count up 15 or so episodes in a 10-minute screen, and that occurs uniformly, those episodes occur uniformly over the course of the night. It looks like for a 10-minute screen, 15 episodes, we come up with an AHI estimated rate of 90 episodes an hour. Very close to what WatchPAT's tabular data generated automatically. And in fact, this is a case that is so obvious that one wonders really whether you would need to dip into the recording itself to confirm anything about the overall level of AHI. But instead, our interest here is much less in the AHI as a number and more in terms of the AHI, whether it's obstructive or central in nature. And I'd like to highlight that in that we see evidence of obstructive events really at first blush on the report itself, in that the REM periods, 3 of those REM periods shown here in the dotted red, are associated with deepening desaturations. And as we mentioned before, with a loss of pharyngeal muscle tone, particularly in REM sleep, we can see worsening upper airway obstruction that accounts for worsening desaturations. It's not the only mechanism, because other things happen in REM sleep in terms of event duration, but it surely is consistent with the notion that worsening desaturations and worsening levels of upper airway obstruction during REM sleep often occur and are more reflective of obstructive than central etiology. The other thing that's absolutely obvious is that there's a whole lot of snoring throughout the night. And the snoring is yet one more indicator that this is a patient, when he goes off to sleep, that is prone to developing upper airway obstruction. And so we've got really 2 very obvious indicators of obstructive rather than central episodes. How do we confirm that these episodes are obstructive? Well, let's walk through 1 or 2 of these episodes as they actually evolve in a 2.5-minute screenshot from the recording example that we took before. And we see that as the airway occludes, things happen in sequence. First, we've got a period of respiratory silence, leading to the reciprocal pattern of the microarousal from sleep. We have then a gradual desaturation here. That occurs as the airway obstructs and oxygen stores in the lungs are gradually depleted of oxygen. But because the arousal occurs in obstructive events in an abrupt fashion, we see that the rate of resaturation is very much steeper than the rate of desaturation. And it's with those resuscitative snorts here, the loud snoring during the apnea termination, that the airway reopens and we see a very brisk or sharp, steep resaturation that's quite a bit steeper than the desaturation itself. And so on the recording itself, we've got several indicators that this is an obstructive episode, not a central one. The period of respiratory silence ends abruptly with resuscitative snorts. The resaturation is much steeper than the desaturation. And then even here, as you look in to the pulsatile PAT waveform, you can see evidence of obstructed breaths as respiratory fluctuations in PAT amplitude occur on a beat-by-beat basis. And we can see some of those respiratory fluctuations even here in the actograph, which is really just measuring movement in the wrist or transmitted through the mattress itself. And so we have several indicators on both the report and on the recording that this is a patient who has severe apnea that's obstructive, predominantly obstructive and not necessarily central in nature. Well, I'd contrast that, if you will, with someone who has predominantly central or Cheyne-Stokes breathing rather than obstructive. We see here on the left panel the case that we just reviewed of a patient with severe obstructive sleep apnea, worsening in REM, a lot of snoring, occurring during the REM periods. Here we see someone with predominantly central sleep apnea. But you can come to that conclusion almost automatically right off the bat. Because central sleep apnea and Cheyne-Stokes breathing in particular is often characterized by not worsening of apnea, but decreases in AHI during the REM periods compared to the surrounding non-REM periods. And in fact, we see that in non-REM sleep here, look here in the middle of the panel, we see that there's frequent O2 desaturations, intermittent hypoxia. But during the REM periods, the O2 desats, oxygen level goes down, but the numbers of desaturations goes down even more dramatically. Well, the drop in SpO2 amplitude is emblematic of REM sleep, but the reduction in the frequency of the desaturations is a very strong clue that this patient may have predominantly Cheyne-Stokes or central sleep apnea rather than obstructive apneas during non-REM sleep. And in fact, hand in hand with that impression is the fact that really we've got very minimal snoring in this individual in the right-hand panel compared to the one in the left-hand panel where the snoring is really quite pronounced. And when we see that there is noise being generated, it is being generated largely by movement arousals, movements in the bed, rather than by snoring per se. So right off the bat, we know we've generated circumstantial evidence from the automated report that we might be dealing with someone who's got severe and frequent desaturation, severe apnea, but more Cheyne-Stokes and central in nature than obstructive. And why might he have Cheyne-Stokes breathing? Well, the answer is really in the pulse rate variability here shown in the red signal. In that this variability is the pulse is highly variable, regardless whether the patient is asleep or awake. This kind of variability that is really much more erratic and irregularly irregular is often the case in someone who has chronic atrial fibrillation. And in fact, that is the case with this individual. So we've got the right cardiovascular substrate for Cheyne-Stokes breathing, the right distribution of apneas between non-REM and REM periods, and the lack of snoring, all of which are consistent with the overall impression, just from the graphic display, that we're primarily dealing with central, not obstructive episodes. Well, indeed, this man's story, a 75-year-old thin guy with no significant sleepiness, on a baseline sleep study showed severe apnea, was placed on CPAP but intolerant. An oral appliance was applied, and the WatchPAT that we see was done with the oral appliance therapy in place. And indeed, what we've got here is potentially oral appliance emergent central or Cheyne-Stokes breathing. And indeed, the automated tabular data confirm our impression that we've got a non-REM AHI of 46 an hour, but a REM AHI that's considerably less at 7 per hour. And Cheyne-Stokes is highlighted by WatchPAT's automated assessment of roughly 2/3 of the night is spent in Cheyne-Stokes breathing. And roughly 2/3 of the events are considered to be central, not obstructive in nature. Well, if we want to confirm the Cheyne-Stokes and central nature of this patient's apnea, all we need to do is look at the recording itself. And I'll fast forward just a couple slides to look at the recording, in this case, a 5-minute screenshot, where we see, as previously, the snore signal, respiratory movements in non-REM sleep, SpO2, raw pat amplitude, and pulse signal. And you can see here that this is a patient who has a waxing and waning pattern of ventilation, with periods of respiratory silence, no respiratory movement or effort whatsoever, and then intervening periods of crescendo, decrescendo, waxing and waning respiratory efforts. And as ventilation gradually increases and decreases through these apnea cycles, we see a much more uniform sinusoidal pattern in the oxygen saturation signal. And it's that pattern that really tells us that, yes, indeed, we see here both in the respiratory effort as well as the oxygen saturation that we're probably dealing with someone who has Cheyne-Stokes breathing. And very similarly here, we see that the arousals, the nadir here in the arousal, or the apex of the arousal, occurs not just at apnea termination, but further on into the hypopneic phase, as is often the case with Cheyne-Stokes breathing. So this is someone who really has predominantly central or Cheyne-Stokes breathing rather than obstructive sleep apnea. And we recognize that from features on both the report and the recording that we've already reviewed. The non-REM predominance, regular consistent dips in SpO2 in non-REM sleep, often associated with atrial fibrillation. And then on the recording, we see the central episodes by a loss of respiratory effort and chest movement signals, the symmetric fluctuations in the respiratory signals and in the SpO2, with a waxing and waning progression as we go into the hypopneic, into and out of hypopneic phase. In some instances, we can discuss later, we can measure the circulation time, which is prolonged, and the arousals are oftentimes delayed well into the hypopneic phase. Well, having done that, I would just like to and having spoken about our ability to glean from reports and recordings, the different patterns of sleep disorder breathing that commonly present to both out of lab as well as in lab testing. What I'd like to do is really just highlight what you're in for if you should decide to take the step with WatchPAT as a home testing platform. And that is visual overreading and manual scoring. As mentioned, we did the Compass project at Hopkins, where we did parallel studies in one and the same individual with standard in-lab polysomnographs that were manually scored the way they're traditionally done, and WatchPAT recordings that were automatically scored. And from those recordings, we developed a rule set for visual analysis of the WatchPAT recordings. And then we validated that rule set in a prospective fashion in roughly 200 patients. When we compared the PSG results to the WatchPAT, we came up at a very high level and global view that the AHI is already fairly good in the hands of the automated report at almost any AHI threshold. But with manual overreading, the purple bars, we can always improve on the correlation between our manual AHI, manually generated AHI, where we edit some of the results of the watch automated scoring. We can always improve somewhat on the accuracy of the automated report. And it's with those improvements that I would really highlight that those improvements are particularly pronounced in the subgroup of people in whom their AHI is in the moderate to severe range on the automated report, but the ODI is considerably less, meaning these events might well be non-specific microarousals that occur from sleep that are not associated with respiratory disturbances. Now, there are 3 buckets of patients that we've identified in whom this is more frequently the case, where we're flagging those studies to look at with a little bit more scrutiny visually as we apply the scoring guidelines. Namely, it's those with suspected arrhythmias and a lot of heart rate variability, those who who are elderly, who might well have periodic leg movements rather than sleep disorder breathing episodes, or a combination of both, leading to this discrepancy in AHI and ODI. And then finally, the premenopausal female, who oftentimes does not desaturate much, particularly during REM sleep, or might, because of reasons of iron deficiency, might have periodic limb movements that's masquerading as apnea. And so these are the three groups that we apply those visual or scoring rules or guidelines a little bit more assiduously to. The others usually pass with a glance at the report, namely the graphic display and the automated tabular data. So I'd like to really highlight that or emphasize that what we've built here is a structured approach to reviewing the WatchPAT study. The reason for doing so is it's so darn convenient and easy to use. At a high level, we can conclude that the automated scoring will certainly save you a lot of time. The WatchPAT reports both sleep architecture, a valid hypnogram, as well as sleep disorder breathing metrics accurately. We've given you a glimpse of how you can dip into the recordings, see the raw score tags for sleep disorder breathing episodes and for sleep staging, and edit them at will. And we've highlighted the fact, haven't at the time, but would be happy to share with you formal scoring guidelines that allow you to edit these recordings with guidance and greater clarity on how you can verify or edit the WatchPAT reports. The bottom line is that when you look at a new technology and you look at a different kind of signal, in this case, it's a cardiovascular signal that's embedded in the PAT technology, we're really looking to tap three different areas of intuition or knowledge. Your knowledge of clinical sleep medicine and the way that specific types of apnea, leg movements, and otherwise present in polysomnography. Our ability to describe the signals with pattern recognition, and our understanding of really neuro and cardiopulmonary sleep-wake physiology that really all conspire together when you're looking at these reports to be able to sort of generate not just a report, but really ratify or verify and confirm the findings on the report and or edit them with some degree of confidence. So I'll stop there and just highlight the fact that there's plenty of other educational resources available to you should you decide you want to sort of dip into this. We've run workshops highlighting some of these cases in greater detail and other cases as well. And stop there for a few minutes to answer any questions or comments that you may have.
Well, Dr. Schwartz, thank you for a very insightful talk and an introduction to this topic that obviously we can dive into for hours, as you mentioned. So I'd like to welcome our group to bring their questions forward, of which I'm sure there are many. I know one that was raised by Dr. Sharika Rahouf was differentiation between REM supine and REM supine apneas, and if you could comment on that. I assume that obviously the actigraph in the wrist monitor is providing some degree of differentiation there, but if you can comment on it, Dr. Schwartz, that would be great.
So if I understand you correctly, the question really is, hey, if there's so much variability in REM sleep in the underlying signals, how do you figure out whether that variability is due to apneas or due to REM sleep?
Well, how are you differentiating, for example, REM-related apneas versus supine-related apneas, or when it's a combination of both REM supine apneas?
Oh, I see. Okay, yeah. You've got to have enough REM periods in both body positions to figure out whether it's just REM sleep or it's REM plus supine sleep that really brings out the apneic activity. Because both are really, and this is the fascinating thing about the physiology, is that REM's doing it's got its own placing its own whammy on the neuromuscular control of the airway and of respiratory muscles in general. But the gravitational effects of positional changes really come out really quite independent of the neurophysiology. And so we've got both a sort of a mechanical component with the positional apnea, plus the neuromuscular change in neuromuscular control between the two sleep states. If you want, you can do 2 or 3 nights of WatchPAT. I'm sure these guys wouldn't object to make sure you get a sample enough REM sleep in all body positions in order to really, if you don't, listen, suffice it to say that if you get 4 to 6 REM periods, you probably are going to be pretty good and pretty confident that you've got that question parsed out. But if you don't, then it may take more than a night.
I know Dr. Rahouf had some questions. I'm not sure if she's able to jump on there.
Dr. Schwartz, thank you so much for such an insightful explanation and detailed explanation of PAT technology. I really appreciate it. So I do have some questions about the reliability of the PAT signal in patients who have arrhythmias, so particularly the atrial fibrillation, and whether there are any effects of medications on the signal, particularly vasodilators or negative chronotropic agents.
Yeah, really good question. First is AFib. We didn't have a lot of time to really speak to it, but AFib leads to a markedly irregular heart rate, and so the reciprocal pattern that I've described, which is sort of the backbone of detecting microarousals, we're sort of flying with one hand behind our back, because you can't count on the rise in heart rate to indicate that a microarousal has occurred. My counter to that is that in practical experience, we still see, despite the fact that you have the arrhythmia in AFib patient, you still see the attenuations, marked attenuations of the PAT amplitude. And then what that does for me is it just simply raises the bar when I'm looking to confirm whether that drop in PAT amplitude is associated with some other disturbance in oxygenation or ventilation. And for that, I've got really 3 signals: the SpO2, the dip in O2 sat, the respiratory movement, and the snore signal. And so from those 3 signals, I want to make darn sure that the microarousal that's detected in an AFib patient only by virtue of the decrease in PAT amplitude, make darn sure that actually that microarousal is associated with some clear-cut disturbance in ventilation or oxygenation. So that's the first part of your question, what to do about AFib. The second part of your question really has to do with, are there contraindications to using the WatchPAT? And we don't know, I don't know the answer fully, but I would be a little bit loath to use WatchPAT if you have someone who's on an alpha blocking agent, primarily because we know that digital arterials are really highly under the control of alpha adrenergic tone. So if you're blocking alpha adrenergic tone with pharmacologic agents, then I think you want to be careful about those patients. Lots of our patients are on beta blockers, and lots of the COMPASS patients who are on beta blockers, probably a quarter to a half of the patients. And while we didn't analyze it specifically, we're not really seeing any impediment from beta blockers per se. The other category of patients that, particularly in Canada, you might be attuned to is frankly patients who have Raynaud's phenomena, Raynaud's disease, since we're talking about alterations in the vascular tone and digital vessels. And so those are really it's those main areas that I might think twice about the WatchPAT. Not necessarily rule it out, but nonetheless, certainly if you happen to have mistakenly gotten a WatchPAT in that kind of patient, you want to be mindful of the clinical background.
have a question, Dr. Schwartz, in my own practice as, as a sleep apnea surgeon, as you know, I have a hard time understanding how to clinically interpret the RDI value that is, reported by the WatchPAT in context of consideration of UARs type symptoms and where and when to intervene based on the RDI, because it appears that the RDI on the WatchPAT, at least in my experience, seems to come back quite a bit higher than what I see on in-lab PSG. And I'm wondering if you can comment on that from your experience.
Yeah, I take the RDI as a non-specific indicator that there may be some mischief going on. But that's really a little bit more from the perspective of a sleep doc. And I agree with you. As a sleep surgeon, I'm not sure I would be making operative decisions based on RDI. And so our focus, and truthfully, the focus in the COMPASS study was on mapping AHI to PSG, not RDI. But nonetheless, RDI is really, really helpful. And it's helpful in the following sense. When I'm seeing a sleep patient who's presenting with nonspecific daytime fatigue, not necessarily hypersomnolence, or chronic fatigue syndrome, or functional somatic syndrome, or POTS, postural orthostatic tachycardia. These are or depression or whatever, or periodic limb movements. I will oftentimes see lots and lots of sympathetic activations that are connected to other types of problems. The really, straightforward example is the PLM patient may pop up with a very high RDI, but a low AHI. Now, it turns out when you look at the record, and those are so I use the RDI as a flag to take a look at the recording and find out, hey, what's generating that RDI? Because although it may not reflect sleep disorder breathing, it may be highly germane clinically. And in some of our other workshops, we review cases of periodic limb movements, which present with exactly that discrepancy.
Thanks for that.
Thank you for a very interesting presentation. I'm just wondering if any work was done about night-to-night variability with, the PAT technology, comparing, if there is variation between, 2 nights or 3 nights, or, just to determine reliability overall in terms of the testing.
Yeah, so night-to-night variability is really very similar to what we see in night-to-night variability on PSG, in that patients with mild to moderate sleep apnea will show you a fair amount of night-to-night variability. I just stumbled across an abstract from a group that actually has studied night-to-night variability. I don't think it's out in print yet, but they're finding that indeed you're not seeing a first night effect. They at least if my memory serves me correctly, they're not seeing a first night effect in the WatchPAT. They did 3 nights of WatchPAT actually.